Hi students, hope you're all doing good. In this video, we are going to discuss about anemia in pregnancy. Okay, so this is one of the very important topic for both your theory and your clinicals, right? So anemia is one of the most common hematological disorder in pregnancy. And once WHO reported that about 40% of the women globally are affected with anemia. And you know what? India is one of the highest prevalence country for anemia, right? So, knowing about anemia and especially its complications, prevalence, clinical findings, everything A to Z is going to be your questions in your clinical exam as well as for your practice also. It is very, very important, right? Okay. Now, we'll see first a classification of anemia. So, classification of anemia. It can be classified as physiological anemia, okay, or there can be some conditions causing anemia, that is some pathological causes of anemia is also possible, right? So, they include either deficiency anemia, okay, so due to some nutrient deficiency, okay, and I hope you are familiar with this word iron deficiency anemia, right? So, it is iron deficiency anemia, okay. Then it can be folic acid deficiency. Then it can also be due to your vitamin B12 deficiency, right? And the next category is about the hemorrhagic causes, okay, some of the hemorrhagic causes that can cause anemia. So, this set includes either due to acute hemorrhage in pregnancy. Acute hemorrhage means, for example, there can be bleeding, okay, that has occurred in early pregnancy, or it would have been APH also, that is antepartum hemorrhage, okay. What are the cause of antepartum hemorrhage? It's placenta previa, previa placenta, anything like that, okay. So, that kind of hemorrhage is also going to cause anemia. And some of the chronic causes, okay, chronic causes like it can be due to hookworm infection, okay, or if there was a bleeding hemorrhoids, okay, if there was a bleeding hemorrhoids, right. So, and also we have some hereditary causes of anemia, right. So, what are the hereditary causes of anemia? Hereditary causes include thalassemia, sickle cell anemia, then some causes like hereditary hemolytic anemia, and some other hemoglobinopathies also, okay. And sometimes, okay, in some cases it can also occur due to bone marrow insufficiency, and there can be some infectious causes, and it can be also due to some chronic diseases, okay, mostly of the renal disease or a neoplasm, okay. So, see, these are some of the causes of anemia, right. So, we will see the definition of anemia first. So, definition given by CDC, okay. So, according to this, in the first trimester and the third trimester, if the hemoglobin value is less than 11 gram per deciliter, and in the second trimester, if the value is less than 10.5 gram per deciliter, okay, then it is defined as anemia. Clear? And so, we will see the WHO definition of anemia. So, according to WHO, there are categories of anemia. Like it can be considered as a mild anemia when the hemoglobin is between 10 to 10.9 gram per deciliter, and it can be considered as a moderate anemia when the hemoglobin is between 7 to 10 gram per deciliter, and it can be considered as a severe anemia when the hemoglobin is between 4 to 7 gram per deciliter. And remember, there is also one category, that is very severe anemia, and this very severe anemia definition is given only by ICMR, that is Indian Council of Medical Research for Indian population, where the hemoglobin is less than 7 gram per deciliter. Clear? So both the definitions are important for you. Okay. And now we'll see what is physiological anemia first. Okay. Now we'll see what is physiological anemia first, right? So physiological anemia. See, in pregnancy what is going to happen? We know that the plasma volume is going to increase, right? Plasma volume is going to increase by 40 to 50% of its normal range, and also RBC value is also going to increase, right? So this is going to increase by 20 to 30%. Okay. Even then both are increasing. What is happening is, you see there is a disproportionate increase. Okay. So both are increasing, but this is comparatively increased more when compared to the RBC population. So what happens is, there is more dilution, okay, that is happening, and it will appear as physiological anemia in pregnancy. Okay, so this is one reason. So there is an increased amount of extra iron needed during the second half of the pregnancy by the fetus for its growth. Okay, so marked increase in demand of iron by the fetus. Okay, in the second half of the pregnancy. Okay, so this is also going to cause anemia in pregnancy. Okay, so if you see this category, there is not only fall in hemoglobin or hematocrit, okay, but there is also fall in serum iron levels. Okay, so if you see the criteria for physiological anemia in pregnancy, the criteria is that hemoglobin should be around 10 gram percentage at least, and then RBC should be around 3.2 million per millimeter cube, and the packed cell volume should be around 30%, and the peripheral smear should show a normal morphology of RBC. Okay, normal morphology of RBC with some central pallor can be there. Okay, with some central pallor. Okay, so this is the criteria for physiological anemia in pregnancy. Next, we'll start with the most important topic, that is iron deficiency anemia. See, iron deficiency anemia, usually what happens in iron metabolism, overall we'll study first. Okay, so what happens in non-pregnant state? See, normal diet contains 10 to 20 milligram of iron. Okay, so normal diet contains 10 to 20 milligram of iron, and we know iron absorption is going to happen mostly in the duodenum. Okay, so iron absorption happens in the duodenum. Okay, and out of the ingested iron, if you see, only 10 to 15% of the iron is absorbed. Okay, so that means if it is going to be 10 to 20 milligram of ingestion, means out of this only 1 to 2 milligram of iron is only going to be absorbed. Clear? And also, so before absorption, what is going to happen is the ferric form. Okay, so you will be taking iron mostly in the ferric form. So this ferric form will be converted into ferrous form. Okay, and once it is entering into the blood, it will be binding to something called transferrin. Okay, so this will be acting as a carrier for transporting the iron in the blood, right? And finally, what will happen is the transferrin iron complex. Okay, that will be stored in various regions, like especially in the bone marrow, okay, muscles, liver and spleen, okay, liver and spleen, okay. And usually there is also a daily loss of iron, okay. So this daily loss of iron is around 1 to 1.5 milligram, clear. And daily loss is suppose exceeding the iron absorption due to various causes, then it will result in iron deficiency anemia, clear? Yes. So in pregnancy, if you take, there is a demand by fetus and the placenta also, right? So the fetus needs some 300 milligram of iron, and for the placental growth there should be 300 milligram of iron, and there is a maternal blood volume expansion, right? So for the maternal blood volume expansion, that is being the RBC mass needs iron, so in that you need some 400 milligram of iron, okay. So totally the total requirement of iron in pregnancy is this 1000 milligram, okay, very important. And if you see again, okay, so there is a loss of around 200 milligram, okay, through excretion, okay. So through excretion means excretion through the feces, saliva and urine. And remember, there is another factor that is happening in pregnancy, that is amenorrhea, okay. So literally amenorrhea is going to act as a gain for iron, okay. So if you take, there are 10 months of amenorrhea, right? So in the 10 months, okay, so we'll be saving 30 milligram of iron per month. So that means 300 milligram of iron is gained due to amenorrhea, clear? So if we see, the daily iron requirement in pregnancy is going to change, okay, and it varies trimester wise. So if we take the daily iron requirement in pregnancy, so in the first trimester there is a need of 1 to 2 milligram of iron per day, and in second trimester we need 4 to 6 milligram of iron per day, and in third trimester we need around 6 to 8 milligram of iron per day. Can you understand? Yes. But mostly this is being compensated, okay, because if the woman has proper levels of iron stores and a proper diet intake, okay, then mostly there will not be any manifestation of iron deficiency anemia, okay. But in countries like India, okay, in countries like India, women already have low iron stores, okay, and despite that the diet intake is also not proper due to various reasons, okay. Low iron stores, and the diet management is also very bad in Indian women, okay. So all these conditions make the need for supplementation of iron in pregnancy. See, remember I already told you the fact that only 10% of the ingested iron is going to be get absorbed, and our daily requirement is at least keep the maximum level, that is, it is going to be around some 6 to 8 milligram, right? So how much amount of daily iron should be supplemented? Yes, it should be around at least 60 milligram of elemental iron should be supplemented, so that some 6 to 6 milligrams of iron will be absorbed, okay. Clear? Now we will see what are the effects of iron deficiency anemia, okay. So if we see the effects of iron deficiency anemia, okay, for the mother, okay, if we see the maternal effects, it can be further classified into antepartum, intrapartum and postpartum effects, okay. So in the antepartum period, it can lead to infections, okay. There can be chance of preeclampsia, okay, or there can be chance of antepartum hemorrhage, or there can be chance of cardiac failure, okay, or there can be even chances of mortality, because remember, this is the indirect cause of maternal mortality, okay, most important cause of maternal mortality. And during intrapartum also the complications are going to be there. Intrapartum complications include postpartum hemorrhage, okay, then cardiac failure and shock. Clear? And also in the postpartum there can be chances of puerperal sepsis or subinvolution of the uterus, and there can be problem with the lactation also, even lactation failure can happen, and there are chances of venous thromboembolism and pulmonary embolism. Clear? So, the complications not only arises in the antepartum period, it is going to occur in the intrapartum as well as the postpartum period, okay, and also for both the mother and the fetus, right. So, we will see the fetal complications in anemia. These include intrauterine growth restriction, then there can be prematurity, or even it can result in stillbirths, and there can be congenital malformations also, and after birth also there is an increased risk of iron deficiency anemia in early ages, okay, of the child. So, the risk of iron deficiency anemia is increased, and there can be increased risk of neonatal deaths also, and also there can be poor mental and psychomotor performance. Clear? Now, we will see what are the stages of iron deficiency. So, if we see the stages of iron deficiency, we have three stages: stage 1, stage 2 and stage 3. See, in the stage 1, the iron stores, okay, whatever iron stores are present, that is depleted, okay. So, it will be like presenting like decreased serum ferritin, okay. So, this is very important point. Iron stores will be depleted and reduced serum ferritin is the first marker of iron deficiency anemia, right. And next one is iron deficient erythropoiesis, okay. So, then the erythropoiesis will be affected, okay. Now, this will present as reduced level of serum iron and reduced level of transferrin saturation, okay, and also there will be increased total iron binding capacity and increased levels of red cell distribution width. Clear? So, that is stage 2. And coming to stage 3, there is iron deficient anemia, okay. So, it is the stage 3 what we are talking about, but actually before that there are 2 stages, right. So, it is iron deficient anemia, okay, and this is where we see reduced levels of hemoglobin and mean corpuscular volume, okay. So, that means if you are seeing a reduced level of hemoglobin in a patient, that means already she is in stage 3 of her iron deficiency stage, okay. And remember, serum ferritin is the most sensitive, okay, and specific marker to diagnose iron deficiency anemia. Okay, most sensitive and specific marker to diagnose iron deficiency anemia. And you will initiate treatment when the serum levels are less than 30 microgram per liter. Okay, so if the levels are less than 30 microgram per liter, at that stage itself you are going to start the patient on treatment, right? Okay. Now we will see the clinical features of iron deficiency anemia. Okay, so clinical features. So let's talk about the symptoms first. Symptoms will include fatigue, weakness, headache, loss of appetite, then there can also be dysphagia, palpitations importantly, okay, and there will be dyspnea on exertion, ankle swelling, paresthesias, then cold intolerance and irritability. Clear? And if we see the signs, and if we see the signs, there can be glossitis or stomatitis. Then sometimes hot murmurs can be heard while auscultation. Then there is a increased JVP seen on examination, and there can be tachycardia or tachypnea, and there can be postural hypotension, and most importantly you will be able to see pallor, dry skin, then koilonychia, that is spoon shaped nails, and dry nails and brittle hair. Okay, so these are some of the clinical features that you will be getting in iron deficiency anemia. So we will see the investigations now. So investigations for diagnosis of iron deficiency anemia. So first one we have already seen, there will be less hemoglobin, right? So there is a low hemoglobin levels. Then if you take the red cell indices, there will be reduced MCV, reduced MCH and reduced MCHC, okay. And then if you take the peripheral blood smear, yes, it is a microcytic hypochromic anemia. So iron deficiency anemia is a microcytic and hypochromic anemia. So next marker we have seen is serum ferritin, right? Now serum ferritin normal ranges between 50 to 150, okay. Suppose anywhere it becomes less than lies anywhere between 15 to 30, then the diagnosis is going to be iron deficiency anemia, right? Similar way, I already told you total iron binding capacity is going to be increased, okay. If you take the normal levels of this, it is around 300 to 350 microgram per deciliter, okay. But anyhow, TIBC we are not going to check routinely because this marker is not that much reliable, okay. So this is not reliable. Next is free erythropoietin receptors. So this can be checked, which will be helping to differentiate between the iron deficiency anemia and thalassemia. Okay, and the serum transferrin receptors. So this is going to be increased, and if you see, this is one of the sensitive markers. But among all these, the gold standard of diagnosis for iron deficiency anemia is bone marrow biopsy. But remember, we are not offering bone marrow biopsy for all women, because we know this is a invasive procedure and a painful procedure. Okay, so definitely we are not offering this. Okay, and additionally, we can do examination of urine. Okay, if there is associated hematuria. Okay, and examination of stool also to rule out hookworm infestation. Okay. Now we will see how to give prophylactic measures for iron deficiency anemia. So the prophylactic measures includes, number 1, we have to give iron supplements in pregnancy. Okay, so according to WHO, you have to give 60 milligram of elemental iron and 500 microgram of folic acid for a period of 6 months. Okay, leaving the first trimester, because iron is teratogenic in your first trimester. Okay, that is 6 months during antenatal period starting from the 4th month, and first 3 months in the postpartum period also. Clear? And next one is, you have to treat hookworm infection. So treatment of hookworm infection, if you see, there is 20% prevalence of hookworm infection in India, and usually in the 2nd trimester we have to give antihelminthic. Okay, the options include albendazole 400 milligram single dose and mebendazole 500 milligram single dose, or it can also be given as 100 milligram BD for 3 days. Okay, and also you have to advise them for improvement in their daily diet habits. Okay, so to improve daily diet habits, including number 1, iron rich food, and number 2, sometimes advising them to cooking food in iron utensils can also help. Okay, and next one is food fortification. Okay, now we are getting iron fortified salt like iodine. Okay, just like how we got iodine salt, like that now iron fortified salt is also available. And I hope you are all familiar with Anemia Mukta Bharat program. So here we are going to supplement them with 60 milligram of elemental iron and 500 microgram of folate. Okay, so this should be ideally started from 4th month of pregnancy, as we have seen before. So that should include 180 days during antenatal period and 180 days after delivery in the postnatal period also. Clear? So, there are 6 interventions that are recommended in Anemia Mukta Bharat, that include: first we have to test and treat malaria in endemic regions. Okay. And the second one, as we have already seen, iron and folic acid supplements plus deworming should be there. Okay. And the third one, even from school going age, that is for the age group 10 to 19 years also, the supplement should be given and iron screening should be done. Okay. And next one, use of fortified foods, as we have already seen. And next one is, we have to give them nutritional awareness, okay, regarding the iron rich foods. And next one, and next one, we have to do a delayed cord clamping for the benefit of the baby. Clear? Yes? Okay. Now we will see the management part. Okay. So, management. See, we can treat iron deficiency anemia by 3 modes. Okay. You can supplement iron either by a oral route, okay, or parenteral route, or suppose if she is in a need of iron transfusion, See, we can supplement iron by 3 routes. Okay. So, first one is we can supplement oral iron. Second one, we can supplement them with parenteral iron. And next one, we have to do directly blood transfusion if necessary. Okay. So, these are the 3 modes of management. Now, if we take oral iron therapy, always remember, this is the first line of therapy you are going to opt for. Okay. So, this is the first line of therapy because it is not expensive and usually there is a need for a longer duration of the time for the iron stores to recover. This is found to be effective with compliance, but it will take a longer time. Okay, but takes longer time. And usually for the treatment dose, we will be using 120 to 200 milligram per day. Clear? And there are various preparations available. Preparations include ferrous fumarate, then ferrous sulfate, ferrous gluconate, okay, like that. Okay. So, any tablet, okay, that is containing 100 milligram of elemental iron, okay. So, that can be given 2 times a day for treatment of iron deficiency anemia. Okay. Now, if you give iron supplements like this, the reticulocyte count increases 7 to 10 days after therapy. Then hemoglobin level increases by 0.3 to 1 gram per deciliter per week. And after doing all these things, what you have to do is, you have to recheck the hemoglobin after a month. Okay. Suppose if there is no improvement, okay, if there is no improvement means you have to check for compliance. Okay. So, how we will be checking compliance means you have to ask the color of the stools of the patient. Okay. Suppose if she says it is being passed dark means then the compliance is said to be good. Okay. Suppose if she says the color of the stools is said to be normal means then you have to doubt her compliance level. Okay. So, usually why this non-compliance occurs means non-compliance is due to gastrointestinal irritation or it is due to nausea, vomiting, and it is due to metallic taste, okay, and there can also be constipation. Okay. Now, what you have to do is, if this is not working out, you have to check for the other causes of anemia like chronic illness or hemoglobinopathies like that. And there is another thing you can do with the treatment. Okay. Like if oral iron compliance is not good means you can shift to parenteral iron therapy. Okay. And remember, oral iron should be stopped before taking parenteral iron therapy. Okay, because if you give oral iron and parenteral iron simultaneously means this oral iron is going to saturate all the receptors and then parenteral iron will not be acting properly. Okay. So, what will be going is both the things will be acting simultaneously and the receptors are going to get blocked. Okay. So, what happens? The iron what we are going to supplement is going to get accumulated and it will lead to toxicity. Clear? Now, remember some of the instructions you have to give to the patient while taking iron tablets. We have to advise them to take it 1 hour before or after meal. Then it is advised to be It is advised to be taken with vitamin C supplements. Okay, like you can ask them to take it with a lemon juice or an orange juice, etc. Because lemon juice and orange juice that is containing vitamin C is going to enhance the absorption. Okay, whereas tannins are going to reduce the absorption. So, you should avoid them to take with tea, coffee or milk. Okay. And remember, we will be supplementing both iron tablets and calcium tablets. So, they should not take it with calcium supplements also. Okay. And between iron and calcium supplements, at least some 2-hour gap should be there. Okay. And they shouldn't take antacids also. Okay. Avoid antacids. Clear? Okay. Now, we will see parenteral iron therapy. See, usually IM route is used to give parenteral iron therapy, okay, but IV iron acts faster than that, okay. So, this is the most common use, this acts faster than that, okay. So, our preparations include iron dextran or sorbitol citrate, okay. Usually, this was given by IM injections, but now IV route is preferred, okay. Why? Because number 1, IM injection is painful, then staining due to IM injections present, okay, and then there is poor absorption and there can be slower mobilization of the iron stores from the IM sites, okay. Then if you take iron sucrose, okay, so this is used most commonly, whereas ferric carboxymaltose is used most effectively, okay. So, what are the indications of giving IV injections means, that is IV iron preparations means? Number 1, there is no responsiveness or they are unresponsive to iron. Then there is non-compliance. Then there is intolerance to oral iron, and there is, suppose there is insufficient time for oral preparation to be active. Okay, and then suppose the patient is having any gastrointestinal diseases. Patients have gastrointestinal disease. Okay, and in some conditions IV iron is also contraindicated. So IV iron is contraindicated in active infections. Then definitely we are not going to give it in the first trimester. And suppose if there is anaphylaxis that is happening to IV iron. So these are contraindications, right? Start chestuname, Satish. So there is a formula called Ganzoni formula. Okay, so it is called as Ganzoni formula to calculate the total iron deficit in this patient. Okay, so the total iron deficit is given as body weight into target hemoglobin minus the actual hemoglobin, okay, into 2.4 plus 500 milligrams. Okay. Now, Ganzoni formula is used to calculate total iron deficit. So, it is given as body weight into the target hemoglobin minus the actual hemoglobin into 2.4 plus 500 milligrams. Clear? Now, what is this BW? This is body weight, right? And total hemoglobin we are targeting is usually around 11 gram per deciliter we are taking. Okay. The actual hemoglobin is nothing but the patient's hemoglobin. Okay. And 500 milligram is for the iron stores. Clear? Okay. Now, if you take iron sucrose, how you will be giving us? The maximum IV dose of iron sucrose you can give is 200 milligram per setting. Okay, and remember, one vial of iron sucrose contains 100 milligram of iron. Okay, so if you want to give 200 milligram in a setting, you have to use 2 vials. Okay, so that will be 2 into 100, which is 200 milligram. Clear? So if you take the infusion rate should not be more than 20 milligram per minute. Okay, so that thing you have to keep it in mind, and remember, we can give 3 doses per week on alternate days. Okay, so if you give the dose on alternate days in a week, I am choosing Monday, Wednesday and Friday. So it is 200 milligram per dose in a day. So 200, 200 and 200. So how many milligrams you can supplement in a week? It is 600 milligram per. Clear? And also ferric carboxymaltose, this can be administered 1000 milligram as a single dose itself. Okay. Suppose if you are planning to give a second dose of ferric carboxymaltose, then you can give it 1 week later. Okay. So 1 week later, second dose can be given. Clear? And remember, for ferric carboxymaltose, no test dose is required. Okay? And we have other iron IV preparations also, like you have iron dextran, then sorbitol, etc. Now these can be given as IM injections. Okay, for this test dose is required and there is chance of anaphylaxis. Okay, and while giving IM dose, we have to give it in a Z-track technique. Okay, so due to this, there can be pigmentation, pain, etc. Clear? So generally, if we speak about allergic reactions in parenteral iron preparations, it is an extremely rare event. Okay, it can happen in 1 in 2 lakh persons. Okay, and usually it is presented as fever, arthralgia or myalgia either during the transfusion itself or within 24 hours of transfusion. Clear? And usually this subsides spontaneously, no need of any specific management, or otherwise conservative management for the symptoms is enough. Okay? And definitely temporarily you have to stop the infusion also. Okay, until the symptoms subside. Clear? Now regarding blood transfusion, see, blood transfusion is given when woman is close to term or woman is in labor or the anemia is severe or very severe grade. Okay, and usually we will be giving packed red blood cells. Okay, packed red blood cells, that is PRBC, especially to avoid fluid overload. Okay, and transfusion should be given slowly. Okay, usually at a rate of 80 to 100 milliliter per hour. Clear? Okay. Now I will give you a summary of management of iron deficiency. Okay. So if you take management of iron deficiency, first we will see the hemoglobin levels, okay, in gram per deciliter. Then we will see the trimester in weeks, and then we will see the mode of management. Clear? So first category where you have hemoglobin less than 5 gram per deciliter. Okay. So when the hemoglobin is less than 5 gram per deciliter, whatever the trimester it is, okay, regardless of the trimester, you are going for PRBC transfusion. Clear? Yes. And the next category is when hemoglobin range lies between 5 to 7 gram per deciliter. In that case, if it is a first trimester pregnancy, then you can supplement them with iron and folic acid tablets, BD. Okay, so that is oral supplements we are going to give. Suppose she is in her second or third trimester, okay, then you have to give her IV iron, that is parenteral iron preparation. Okay, so this is up to 30 36 weeks we can keep. Okay. Then after 36 weeks means we should prepare her for delivery, right? So during that time, it's ideal to do blood transfusion as such. Okay, that is, we'll be preferring again PRBC. So PRBC transfusion. Clear? And the next category is, and the third category is where hemoglobin lies between 7 to 9 gram per deciliter, and in this category, whatever the trimester is, okay, all trimesters we can give iron and folic acid BD, okay. So that is oral supplements, okay. Suppose if it is above 36 weeks and the hemoglobin levels are less than 8 gram per deciliter, we have to prepare her for labor, right. So that time you will consider IV iron, okay, because the hemoglobin is less than 8 only, okay. So next category is where the hemoglobin is between 9 to 10.9 gram per deciliter, okay. So in this category, whatever the trimesters, that is in all trimesters, you are going to supplement them with iron and folic acid BD orally. Clear? So now after this, what we will do is, after oral and IV iron management, we are going to repeat the hemoglobin after 1 month again. Clear? And suppose if target hemoglobin levels are achieved, then we can continue the iron and folic acid BD orally itself. Okay. Suppose if the target hemoglobin levels are not achieved, okay, then what we have to do is with oral iron treatment. Okay, suppose if the patient is on oral iron treatment, and she is in her first trimester, we can give blood transfusion. Okay, and remember, parenteral iron or IV iron is contraindicated in first trimester. Clear? And also, suppose with IV iron treatment, okay, and patient is on her second and third trimesters and still the target hemoglobin levels are not achieved, then what we will do? We can repeat a IV iron dose. Okay, so this can be repeated again. Clear? Yes. Now, we will see about the intrapartum management also. Okay, so if you take the intrapartum management in anemia in pregnancy, first, cesarean section is only for obstetric indications. Okay, keep this in mind. Okay, cesarean section is only for obstetric indications. And what is the aim is? Aim is to deliver the woman vaginally. Okay, but with some precautions. So what we are going to do is, we are going to avoid IV fluid overload. Okay, then we have to supplement oxygen and keep the woman in a proper position. Okay, also you can give sedation and pain relief during labor. Also, you have to cut short the second stage, okay, by prophylactic instrumental deliveries. Okay, you can use either vacuum or forceps, and remember, avoid pervaginal examinations also. Okay, don't do multiple pervaginal examinations. Clear? So definitely you should do active management of third stage of labor and supplement them with oxytocics to prevent postpartum hemorrhage. Clear? Okay. How will you do a postpartum follow-up now? So, postpartum follow-up, IFE to be continued at least 3 months, and ideally 180 days, that is 6 months. Okay. Suppose there is severe anemia, okay, then you can even supplement IV iron dose, okay, that is you can supplement them with a single dose of ferric carboxymaltose, okay. What is the dose? IV 1000 milligram, okay. So this can be given, and remember the contraception for adequate spacing in iron deficiency anemia is also important, okay. So you can advise them with progesterone only pills or combined oral contraceptive pills, right. So with this we are finishing the discussion on anemia in pregnancy part 1. We have discussed in detail about the iron deficiency in pregnancy. So until we meet in the next video, happy learning, take care and bye bye.